cookies. We're going to get onto GI surgical problems. And as with the last talk that I gave you, I'm trying to come from the standpoint of not teaching you everything there is to know about anomalies in the fetus and the newborn, but we're trying to give you enough information to equip you with the knowledge to go out and recognize what is it. That's the most important thing. Do you know what you're dealing with? And secondly, really how to manage it. Because you don't really need to know extreme detail about the long-term complications. Having said that, if any of you are interested, we can always talk about that at another time. I'm sure I've thrown a few things in here. But we're going to look at, these are four common things that we see. We don't go out for very many omphalocele, gastroschises. You certainly will go out for an obstruction of the GI tract. They won't come with that stamped on their forehead, of course. But if they have emesis and there's no history of stooling, that would be a good clue that there's a blockage somewhere. And neck is something you will see. If you've not seen neck before, I guarantee it, on the transport team, you will wind up going to pick up a baby who has developed neck somewhere. Most likely places being either Brandon or Thompson. Okay, so this is what's called an omphalocele. Okay. Now, I guess to make it interactive, I could have asked you what is that, but so what is it? Does anyone know off the top of your head what is the difference between the two? How do I look at that and say immediately that's an omphalocele?
It's covered.
Well, that was easy. Right? It's closed. Okay. Now, having said that, you can have what's called an inflammatory peel. I don't know if anybody's ever seen that. When the bowel is floating around, for gastroschisis, when the bowel is floating around exposed to the amniotic fluid, if it's there for a long time, it can get quite matted, and so it comes out looking like a ball. I don't know if anybody's ever seen that. So really, what you're looking for is not just a covering, although this one is pretty classic, but you're looking for one, it's perfectly round. Okay, so that's clearly to me completely covered, and it's not just inflammation and thickened exudate on it. The other thing is you can see the cord coming off the mound, if you will. Okay, so gastroschisis occurs to the right in almost every single case. It almost always is to the right of the umbilical cord. And the other thing is you'll be able to identify a normal umbilical cord. Now, when I say normal, it sometimes looks a little stringy, but you'll be able to say, okay, that's the umbilical cord, whereas with omphalocele, it's quite big. Now, with an omphalocele, and the other thing you might question is, if an omphalocele is a midline herniation of organs, okay, and intestinal content, then how would that differ from an umbilical hernia? Because whether in PICU, we don't see very many in NICU, but certainly in PICU you'll see children with umbilical hernias. And so, in the interest of time, I'll tell you the most common definition is if the base of the hernia is greater than 5 centimeters in diameter, we call that an omphalocele. If it's under 5 centimeters in diameter, that would still be considered a hernia.
And you could get a call for an umbilical hernia because one of our colleagues on transport did get a call and she thought she was going for an umbilical hernia and got there and
It was an omphalocele.
This is what it was.
Yeah.
It was huge.
So the thing about omphalocele is that it's important to remember is, excuse me, about 30%, so about 1 in 3, have something else going on. So that stresses the importance of doing a very, very thorough newborn exam, when you see one of these, because there could be, and they tend to be in the midline, so you could have a murmur, so there could be a cardiac defect. Very important to check the palate. Not uncommonly you'll find a cleft palate in a child with omphalocele. They can have central nervous system abnormalities, genital abnormalities. Essentially, if you draw a line right through the middle of the baby and you think about all the organs that happen, all the way from top to bottom, that's what can be abnormal. So it is associated with other syndromes, trisomies. BWS is Beckwith-Wiedemann syndrome. So the hallmark there is if you go and find a baby with omphalocele, always check a sugar, because I know this is getting repetitive, we always say you should check a sugar, but in this case, these kids have hyperinsulinemia, and so they can They can be profoundly hypoglycemic. And, to give you guys a pat on the back, when we look at outcome for kids with Beckwith-Wiedemann syndrome, and we don't see very many, I would say we see maybe one every couple of years. But when we do see them, if you look at groups of Beckwith-Wiedemann syndrome and you look at them long term, and I should tell you that they have a big tongue, they tend to have almost like a hemangioma on the forehead, and then they have hyperinsulinemia with the omphalocele. When you see one of these kids and you look at them long term, the predictor of neurological outcome is what happens in the first few hours of life. So if they avoid hypoglycemia, they're normal. Okay, they grew up normal. If they come in and they've had multiple episodes of severe hypoglycemia, they're mentally retarded. So you guys will be the front line. You'll be able to say, we saved that child, from a lifelong mental disability, assuming you get the dextrose in. And then pentalogy of Cantrell is you've probably seen one here at some point. Neonatology may not have seen it, probably would have, actually might have gone directly to Edmonton for surgery, but do you know what pentalogy of Cantrell is? Anybody know that? So I should know all the definitions, but essentially pentalogy of Cantrell is where you get something called ectopia cordis. So the heart's on the outside of the body. It's very disturbing kind of yeah, the heart's covered by, so yeah, as soon as I said that, I realized if you had seen it, you'd remember it. Yeah. When nobody stuck up their hand, I figured, okay, clearly nobody's seen a heart on the outside of the body. Because that's the only thing that, ectopia cordis is the only thing I'm aware of that where it ever occurs is pentalogy of Cantrell. So the pentalogy, of course, means 5 things wrong. So testing my own knowledge. If I'm not mistaken, it's the ectopia cordis and then a cleft sternum because the heart has to come through something. And then you have omphalocele, genital abnormalities, and you can have, I think, spinal as well. But you might want to look that up. The spinal is an iffy one. And so, as far as if you're wondering why does this occur, it occurs because, not pentralogy, but omphalocele, occurs because in the fetus, when your abdominal wall is forming, the lateral folds, okay, which are going to form the abdominal musculature, they come up along the side of the fetus and then they meet in the midline. Has anyone ever seen you'll remember this too, has anyone ever seen a prune belly syndrome?
Yeah.
Ah, okay, everybody remembers that because you know the prune-like belly. So in prune belly syndrome, it's the same problem. The problem being you get this bladder hypertrophy. The bladder gets so huge, it actually blocks the ventral folds from coming over. Okay, and that's why you have no abdominal musculature and you get all the wrinkled belly. So same idea. Except in this case, it's just primary failure. So it's not secondary to obstruction, it's primary, it just doesn't come. And again, if it's small, you get an umbilical hernia. And then I mentioned about the midline defects. So I hope I've impressed upon you that as opposed to gastroschisis, which you'll soon see is almost always isolated, this is a condition where you really do have to think beyond a lot more as a transport team than just the defect. There could be a lot of other things wrong. So again, usually is covered. It can rupture. Certainly if it ruptured, you'd want this child on ampicillin and gentamicin. Many surgeons would probably say due to the risk of rupture, they'd start antibiotics anyway. Certainly if it's leaking, you'd want some antibiotics. Closure depends on size. I've seen everything from a primary closure to a stage closure to just saying to hell with it, we're not going to close this, which I've seen Nathan Wiseman do a few times where he basically just paints it with a sclerosing type agent which hardens it up, and then over time it granulates over and so forth, and then he does closures at a bigger age. I saw some nods, so I think other people have probably seen that. Interestingly, if there's one thing that omphalocele has going for it, it's the bowel is usually normal. You can contrast that with gastroschisis, which has about a 1 in 20 risk of having an associated bowel obstruction. I don't know if everybody knew that you can have about 1 in 20 babies born with gastroschisis have a bowel atresia. And if you think back over, because we see a lot of gastroschisis, if you think back over the gastroschises, you probably each of you can think of one where the baby had to go back for surgery because they had an obstruction. Yeah. So, you know, with any bowel issue, you want to place an OG or an NG, put it to intermittent suction, try to decompress that bowel. As I mentioned, antibiotics would be a good idea. So, thinking about you as the transport team, the other things will be important, like most of the other things will be important to document that you suspect something's there, but you won't necessarily manage it right away. So for example, whether they have a heart defect or they don't have a heart defect, what might be your steps in determining whether this is likely to be a significant, let's say there's a murmur. Sorry, have we done the cardiac yet?
Mm-hmm.
Yeah, that's right, we did cardiac. So let's say there's a murmur. What would be your clue that this is maybe something you need to do something about urgently versus we should just let the team know when we get there that we think the baby has congenital heart disease?
You have decreased pulses, like.
So feel the pulses, right?
Four limb BP.
4-limb BP. Okay.
Your pre and post.
Pre and post ductal sats, right? So if your pre and post ductal sats are the same and they're normal, if your 4-limb BP is okay, and by the way, I will give you permission to do a 3-limb BP. I'm okay with that, or even a 2-limb BP. I've never understood, this is a little aside, I've never understood why we do 4-limb VPs. It makes no sense whatsoever when you think about anatomy. Okay, so the right hand or the right arm is always preductal, right? Well, there's one exception of that. Something called an aberrant right subclavian, which in PICU you might have seen, in NICU you might have seen too. But it's almost always preductal. So if you have a preductal blood pressure and you want a postductal blood pressure, you never want to use the left because the left actually could be, in a small number of patients, still preductal, okay, depending on where the ductus inserts. So that's why it's very unreliable. And as for the legs, you could say, well, okay, maybe you don't do the left, but you can still do 3-limb blood pressures. But you're not going to have a difference between your right leg and your left leg. You may have simply because of your non-invasive equipment, the way it works, you may get a bit of difference. And I know as a team you see that, where you'll say blood pressure was 64 on 35 in this leg and it was 55 on 29 in this leg. Unless they've got, you know, a discrete narrowing in a blood vessel, which they won't, you know, you're going to have essentially the same blood pressure. So even if you get 2-limb, and the only reason I tell you that is not to say you shouldn't do this, but just sometimes I know when we get the report that you fight and you fight and you fight and you fight to try to get that blood pressure and it just won't work. And so if you're having trouble with one of the legs, try the other leg. And as long as you report a lower limb blood pressure, that's fine. Right, so you'd want to determine whether or not there's significant cardiovascular disease, but the big thing for this, like, because the spinal abnormality is not a big deal to deal with acutely, because it would be lower. It's not cervical. Okay, so it would be lower spine, like a spina bifida type of situation. So there's nothing really to deal with there, but the blood sugar will be the important one. Do not leave an omphalocele without checking one. Okay, so this picture could not demonstrate it better. So there's the cord, there's the right side of the cord, and this mass is coming off the right. Now, this may warrant an ooh and an ah when I tell you why it's. Does anyone know why it's on the right? It's a very interesting. Well, there's multiple reasons why it could be on the right, but one of the theories is that there's a vascular interruption of vascular supply to the right side of the umbilicus. It leads to a weakening in the umbilical, or on the right side of the umbilicus, and then herniation. I don't like that one. I don't think that makes a lot of sense, because why wouldn't it happen on the left? I've never understood that. But the one that does make sense is that, did you know in fetal life, you start off life with 2 umbilical veins, and you start off life with 2 umbilical arteries? Did everyone know that?
Mm-hmm.
I'm glad you didn't, because then it makes the story interesting. So, prior to birth, the right umbilical vein regresses. Okay. When it regresses, it leaves a point of weakness. Okay, and that point of weakness in some babies is thought to lead to the bowel coming through and gastroschisis. So that's the one that makes the most sense to me. Now, the reason I also bring this up is because about a month ago, I got a consult for a child with 4 umbilical vessels at birth. And so my consultation was, and you might see this, or you might not. My consultation was, I would do an ultrasound, make sure it's not something called a patent urachus, because you can have does everyone know what a patent urachus is? Because that would fit sort of in this talk. So patent urachus is from the bladder, the trigone of the bladder, okay, so one of the corners of the bladder, to the umbilicus. In utero, there is a connection called the urachus, okay, and the urachus is meant to go into the allantoic sac for you embryology nuts, okay, so what's supposed to happen is the allantois regresses, the urachus is supposed to regress. When the urachus doesn't regress, what you've got is a connection coming out the umbilical cord. It's a fourth hole, okay? And that fourth hole can pass urine because it's connected to the bladder, okay? So if you ever clamp the cord, cut it, and you see 4, and this clear stuff is coming out, it's probably a urachus, okay? So you can do an ultrasound, you can see the track going to the bladder. So that would be one, but the other thing is it could have been a patent or a persistent umbilical vein. So the reason I tell you this is because the next day I got a phone call that the next day I was at St. Pete and there was a baby born with 4 umbilical vessels. And so I'd never seen it before, and I spoke to Sabas Mentacoglu and Carol Schneider over in fetal assessment, and they said they've never seen it. And so we had 2 in the span of 2 days, which I thought was unusual. But getting back, so that's another GI or urological issue. But yeah, if you ever see 4 vessels or 4 holes, beware, it could be a urachus. Okay. So anyway, this is where it comes. Now, gastroschisis, so you get this weakness, but the lack of closure, that's the third theory. So one is the vascular, the second is the lack of regression, and the third is that maybe you get this lack of ventral closure, similar to omphalocele. But again, I don't understand if it's lack of closure, why it would always happen on the right, because I don't know if anybody's ever seen a gastroschisis happen on the left. I've never in my life seen it, but it's almost always on the right. So the risk factors, I think you probably, for those of you who worked in NICU, you could recite these off the top of your head. These mums are always 16 years old, 16, 17 years old. Smokers, Nathan Wiseman reported some 30 years ago that pot smoking was higher in this population. He has since rescinded that and said that as an older man, he's now recognized that young people like to smoke pot. And so he thinks that's why it's just more prevalent in this. Having said that, there is data out there supporting the use of or the linkage with gastroschisis and marijuana. So I've challenged Nathan on that. I think he's actually correct. We also know that Manitoba is a hotbed for gastroschisis. In particular, the rate in northern Manitoba is completely out of proportion with the rest of Manitoba and the rest of Canada. I can't give you the number per 1,000 that's being born, but it's very high. So we don't know if that's because of the preponderance of teen pregnancy, in the north, whether it's excessive marijuana use, whether it's proximity to bad water supply, but there's something. So you're almost certainly at some point going to be called about a baby born with gastroschisis. Having said that, we do our best to try to ensure they deliver here in Winnipeg, but once in a while, I don't know, can you ever think of one? Yeah.
The no prenatal care, 16, 17-year-old woman, yeah.
Yeah. So as far as the transport team goes, the most pressing need these kids have is prevention of dehydration. What you can imagine, maybe, when your bowel is all exposed, the water loss to evaporation. You've got this very moist structure, it's hot, 37 degrees, and it's just dry air outside of it, cool air, it's just going to evaporate. And so these kids can get rapidly dehydrated very quickly. So very commonly we first thing you want to do is cover it. So we have the bowel bag, and I presume you guys have you seen the bowel bag? No. Mm-hmm. So very important to get the baby into the bowel bag, tie it, make sure that the bowel's protected. You want to place the baby a little bit on the right, because you've got to remember, you want to bank them to the right. You've got to remember, what's coming through this very tight opening is the mesentery. Okay, all the blood vessels supplying the bowel are coming through. So if you have them, and it's coming on the right, so if you hang the baby to the left, you're getting, like, it may kink over the tissue, over the umbilical ring, okay? If you hang them, if you put them upright, and the bowel falls to the side again, you may get pressure on the blood vessels. But if you bring them to the right, and it's coming out the right, there should be nothing causing pressure on it. So it's important, especially using a clear bag, to be able to see the bowel. We used to, you know, I'm old enough now, I remember we used to wrap them. You know, remember that, into a nice ball, and they looked pretty, you know, and you didn't see them. Except the problem was you had no idea what was under there. So now we use the clear bag, and it allows you to see the bowel. So that's very important. Typically, we will not run D10 because if you were to run, because typically we'll run anywhere from 150 to 200 mils per kilo per minute. You know,
Per day?
sorry, per hour, per day. Sorry, it's the cold getting to me.
Whoa!
Yeah, and we split it. So typically I would run 75 mils per kilo per day of normal saline and 75 mils per kilo per day of D10. You're basically making yourself D5 half, you know, by running something like that. And so you run that until the bowel is covered. So if the when the baby gets back here, and if they do a closure or they put a silo on, the evaporative loss stops or is much reduced, and then what you do is you reduce the fluids down maybe to 100 per kilo per day. And the reason you do that is because then you don't want to swing from being dehydrated to dilutional and have sodiums of 110.
So do you guys wet the bowel at all, or you just put it in a bag?
And just put it in a bag.
And the omphalocele, do you put any like moisture?
You know, that's a good question. I used to see before the surgeons would come, we'd put wet saline gauze on them. Kathy, are we still doing that?
It
'Cause
depends
I haven't
on
seen one
if
for
the
ages.
omphalocele is intact or not.
Yeah, if it's intact.
Yeah.
Like, don't you
'Cause-
keep it wet until the surgeon can see
Yeah,
it?
I think you still do. And then I've only done it once, but the sac had broken, so we covered it and then put the baby in a bag.
Right.
And the thing with like you were saying, Michael, the way we used to do it with wrapping it,
Yeah.
we used to put gauze, saline soap gauze, and then saran wrap. But everybody knows with saran wrap, you want to make it nice and tight, right? So you were cutting off the circulation and stuff. So it was
Not
just
good.
it was just the bags.
Yeah.
In the OR, anytime there's exposed bowel like that, with these kids, they're always, if they're there, or whatever, just if they're in the gut, then it's always covered
Mm-hmm.
with sweat gauze.
Yeah, I don't think you can go wrong with keeping moist tissue moist. You know, I think, and knowing the insensible water loss is high. And especially if you're out in the field, the last thing you want is to completely desiccate that bowel and have it completely, like the omphalocele, to have it completely dry. You could always put the bowel, rather than wetting it, because I don't know that I can't remember the last omphalocele we transported in, but you always could put it in a gastroschisis bag
Yeah.
just to make sure the moisture's there, rather than manually wetting gauze the whole way down. That would probably be the best bet. So here, the management has gone very much to non-invasive, meaning don't intubate, don't paralyze, don't sedate, because the surgeons now are doing what's called an umbilical flap, where they simply push the bowel back in and then they use the umbilical cord to actually seal the hole, and then it just granulates in. So you can do that without ever intubating the baby. Now if you're up in Churchill and you have to make a long flight and can't reduce the bowel, one thing that can lead to a lot of problems for the baby down the road is if they're breathing and they're inflating that bowel. When they get down here, the surgeons won't be able to do anything. So in that case, I would intubate, I would paralyze so they're not swallowing air. And they gave me, so I guess fluids, I have a slightly different number, 120 to 135. I would tend to use 150, sometimes even up to 200, depending on the size of the defect. And no DCC is no delayed cord clamping. They may also, that might be controversial now, to be honest with you. You know, I think that there's probably no real harm in doing delayed cord clamping. Having said that, we don't do a lot of delayed cord clamping in term infants. A lot of these kids are 35 to 37 weeks. But if the obstetrician wanted to do it, I wouldn't necessarily argue with them.
Shouldn't we not put UAs and UVs in these kids and leave their cord really long? If we're
Yeah,
out?
but Yeah, no, I would, it's an interesting question. I used to put UVs and UAs in all of these kids because I felt that we knew they were going to have problems down the road. We know they're going to take forever to feed. But then I found the surgeons were bringing them all back with the UVCs and UACs out because they wind up sacrificing the cord as part of the, when they do the repair, they have to get those lines out of there because it's in their field. So no, I wouldn't put a UAC UV, I'd put a peripheral IV in place. Having said that, if you are, if you're making a long trip and you're worried about dehydration, it wouldn't be a terrible thing if you could get the UVC in. I wouldn't do a UA, but if you could get the UV in for the trip, then you have a very stable IV for the trip.
The only reason I'm saying that is because don't they want the long cord
Oh, I see, to use it.
so that you're saving the cord?
Mm-hmm. You're right. I mean, now, see, that's interesting because now that they're doing the umbilical flap, they're going to want the cord longer. So yes, for that reason, you know what I would do in that case, to be honest with
A
you?
low?
No, I was going to leave it low anyway because you're not going to get it's almost impossible because of the way the cord is distorted to actually get a really good placed line. What I would do is ask the neonatologist to speak to the surgeon and ask them what kind of repair they're going to do. Because what you might do is you might take a snapshot of the baby, and let's say it's a massive hernia of abdominal contents. So it's a massive gastroschisis. The surgeon might see the picture and say, oh, I can't reduce that with a umbilical flap. This will be a silo reduction. And they might say, go ahead and place the UVC for safe IV access. So I'd have that dialogue and see what they think. If it's a small defect, they might well just do it.
That brings up a good point. Do we have regulations on sending you guys pictures?
So here's my take on it,
Okay.
and it's based on talking to Rachel Porter, the privacy officer here, because we've gone back and forth over this a number of times about photos. Okay. So ideally, you should have the consent of the family. So if you're taking if you want to send a photo, I would ask the family, for the purposes of care, may I take a photo of your baby? Now, if mom's unconscious, or I'll give you the worst case scenario. Mom's unconscious, there's no father in the picture. She's had a general anesthetic. What I've been told numerous times is that clinical care trumps privacy.
Okay.
So if you need to do something, and you've looked at, that you need to do something to help a baby, or a child, we can't think about just babies, but any child, if you need to do something and you've thought of, and you've tried to find a way to preserve privacy, but there isn't. So you're in a place that does not have telemedicine on a secure network. And the best thing you can do is to take a photo or even FaceTime if they have Wi-Fi or what have you.
Okay.
Shouldn't have been Apple specific. FaceTime, whatever the Google one is, chat, and whatever you want to use, you use it. And so I'll give you the example I do. When I'm at St. Boniface Hospital and I'm managing the newborns there, if I've got a dermatology case or if I've got a bizarre rash, something like that, and I want ID to give me an opinion right away, I snap a photo and I send it to them.
Okay.
Because there's no other way, because otherwise I'm waiting half a day for them to show up. And I documented in the chart, spoke to mom, consented, or if for some reason she wasn't around, an apprehended baby, what have you, she's left, I would just say no family available and give consent, but document and say this was the best option to expedite care.
Okay.
Yeah. So this, if you've not seen, I threw this picture up there just because this is a silo reduction. Some of you would have seen this, not all of you would have seen this. The important thing there is the baby's not intubated. And I really, really think, I've had this debate about this, with some of the surgeons, well, the old school surgeons, I'm going to sound terrible by saying that, but the older surgeons tend to say, oh, just intubate them and get it over with, and just do it. The newer training, people coming out of modern surgical training now are being taught this method of actually not intending to do a primary reduction. They're taught to just do silo and let it gradually go in. I would say as a parent, if I saw my baby born with the bowels on the outside, and then they're intubated and paralyzed and on fentanyl with lines and the whole 9 yards, that to me is very traumatic. This, might look disturbing, but it's not as traumatic. So depending on your school of thought, you may see this, or you may see the primary reductions. So certainly, we're doing the umbilical flap, first described in the European Journal of Pediatric Surgery, 2011, and silo we talked about. Intestinal obstruction, this may seem obvious, but it can occur anywhere, from the esophagus all the way to the anus. I mean, you've seen esophageal atresia. Well, you may not have yet, but you will see esophageal atresias. You can see in perforate anus. A tip about the anus that I would recommend is make sure when you look at the bottom end to actually part the cheeks, okay? Don't just, like some people, what they'll do is they'll start to do the exam and they'll see a little bit of stool just on the cheeks and they'll say, oh, they mect, so that they can't have an imperforate anus. But they could have an imperforate anus with a fistula. Okay, so you want to see that the anus is actually, the hole is right in the center. Because if the hole is just off to the side, that could be a fistula. But the principles are the same, and that's why I'm not going to go through every single obstruction that exists in the GI tract, because at the end of the day, you've got a problem of stuff can't get through. It's a blocked sink, okay? And you've got to relieve pressure, as the title says. So, relieve pressure from obstruction. So with the esophageal, the esophageal situation is different because you use a replogal tube, which is one of the only, I can't think of what else you would use that for. Is there another GI condition you would use that for? I've seen it used with esophageal atresia. The idea being there is that you have this pouch and you want to drain the pouch. And why do you want to drain the pouch? Because the child's constantly making saliva and it'll pool up in the pouch and just fill up, and then spill into the airways. So you want to try to minimize that. With lower obstructions, and that can be anywhere, it could be pyloric outlet obstructions, so you could have a pyloric stenosis, you could have duodenal atresia, jejunal atresia, ileal atresia, colonic atresias, duplication cysts blocking the intestine. But the bottom line is you need to put a tube down, you need to put it in intermittent suction. And I'd like to stress there, it has to be intermittent suction. Now, I realize I'm speaking to some nurses and RTs who I'm sure are familiar with suction, but continuous suction will eventually lead to ulceration. So we need to use intermittent.
Even for a short period on transport?
Do you not have intermittent?
No.
Yeah.
Oh,
What's that?
well, I mean, if you don't have it, then...
Well, that's why I'm asking.
Well, no, I mean, you use what you have to, because I would say if you don't have intermittent, then you're stuck. I mean, you use what you have to. Thanks for telling me that. I didn't realize that you didn't have that capacity.
We don't carry repogals either, so.
Just manually.
So you just
We
manually aspirate it? Yeah.
Keep, yeah.
Good to know. Okay. So I won't ask you to take Repogol too. Now the other thing is sometimes these kids, and you've seen them, where their bellies are so distended and they actually have tachypnea, they might have labored breathing. Oftentimes when you decompress the belly they get much better. Antibiotics are interesting. Interesting because I've worked with surgeons that don't use antibiotics for these bowel obstructions, and I've been with surgeons who are adamant you have to be on antibiotics. I tend to be on the side of starting antibiotics myself. I only tell you that it's debatable because if you're out on a transport where the home-based doc says, no, I don't think you need antibiotics, and the next time you go out for one, the home-based doc says that you do, it's because really, if it's an obstruction, unless you get an enterocolitis from the bowel being so distended that bacteria just start translocating across the gut wall, you're not really likely to have an infection. Having said that, there are people that get very worried about possible obstructions, so and enterocolitis, so they prophylactically put them on. And again, the antibiotics are simply Ampangent. So this is the classic sign of the coiled NG tube. Okay. What I was going to tell you, I was fooled once. I can't remember how I was fooled with one of these, but I know what it was. This is actually quite funny. I kept passing the NG tube, and I think what happened was I put it down very far, and what had happened was it had actually coiled a few times. So, normally what happens is if you try to put this down, it goes in the pouch and it comes right back out. It comes out the mouth if you're putting it down the nose. This one time it coiled and coiled and coiled in the pouch, and so I didn't. So when they told me there was a esophageal atresia, I didn't believe them because I said, well, the tube's down like that far. But anyway, that can happen. So TEFs, you're not going to see very many of these. The reason that you won't see very many, the one situation you may see, and even then might be tough, is moms with no prenatal care. This could pop up, but those mothers, to get no prenatal care, they'd have to be pretty strong women. Because how do these women present in pregnancy? Do you know?
Polyhydramnios.
Right. They get huge polyhydramnios, okay? Because the fetus can't swallow the amniotic fluid. So what happens is the amniotic fluid keeps getting produced and there's no way for the fetus to digest it and get rid of it. So it just gets bigger and bigger and bigger. So these mothers would be, very, very big. They often have to have amnio reductions. So you may or may not see this. You shouldn't see it. But anyway, the most common type is that proximal pouch with the distal TEF. I don't know if you all see that there. So where basically the stomach is connected up here. And then there's all sorts. This is the so-called very elusive H-type fistula. I'm sure if you worked in PICU or you work in NICU, this is the one we always look for, and I've never found. I've tried. It exists, but it's tough to find. So these would be the kids that. This is actually the more common scenario you could get called for. So this would be the child that's, let's say, a month old, admitted to Brandon, comes into Brandon Emerge overnight, and keeps having these choking spells with feeding. He's choking, and turning blue. And then he gets an esophagus, he gets an upper GI series looking for this, looking for any of the contrast to enter in the airway. I'm sure somebody here has seen it. I've always looked for it. I've personally never found one, but in PICU, you must have seen one. No?
I can't remember what type, but we've had them.
Yeah.
I know I picked up a kid in Brandon one time, but I can't remember
Was it?
what type it was, but it was the coughing, choking.
It's probably the H-type. I mean, they exist, so you'll see it at some point.
Seems to me I remember seeing on the Cardex H-type.
What's that?
Seems to me I remember reading on the Cardex
Yeah.
H-type because it's such a.
Well, you will see us look for them. It'll be on the patient list. It'll say query H-type fistula when we can't figure out why this child keeps choking.
So those babies wouldn't, or the moms wouldn't necessarily.
They won't have polyhydramnios, no. No, but as you saw, it's only 1 in 25. And I think the incidence of this might be like 1 in 3,000 or 1 in 4,000. So you're looking at 1 in 25 of 1 in 3,000. So it's like, you'll see one of them every, 7 to 10 years in Manitoba. Something like that. Okay, so anyway, be vigilant, like with anything, with all of these, like with omphalocele, if you see esophageal atresia, be warned that it often is associated with vacral and charge associations. Did you guys know what these two things are? No? So we have a child, we just sent a child from the NIC when I was on service who had vacral association. Okay, so vertebral anomalies, imperforate anus, cardiac, tracheoesophageal fistula, and this is renal anomalies and limb anomalies. Okay, so I don't know if all of you guys saw that. Well, if you would have seen that baby who was in bed 12.
Maybe.
Yeah, he had an imperforate anus. He had everything. The only thing I think he didn't have was a vertebral. But he had renal, he had limb, he had a foreshortened right arm.
Can you say what they all are again? Sorry.
Oh, sorry.
I read very
Vertebral, imperforate anus, cardiac, tracheoesophageal fistula, that's the TE, renal, and limb.
Thank you.
And then charge association, it's tough to know what charge association really is anymore. When it was, the reason it's called charge is because these all stood for something. So this was coloboma. So you have retinal coloboma, that's a missing part of your retina. Heart, and this was abnormal facies, so dysmorphic. This one was renal, G was genital, and E was ear. The reason I say that it was called that is they've changed the criteria so many times that heart's not even part of it anymore. I won't tell you what they are. All I'll tell you is there's a huge amount of overlap between these two. So you'll often see, with time, as you're seasoned veterans of the transport team, and you're following up on the patients, you'll see in almost all cases, when you look at the genetics consults for babies, let's say you bring in that are dysmorphic, you'll see that it says query doctoral, query charge, because there's a lot of overlap between them. Certainly if you see duodenal atresia, be aware that there's a very high frequency of trisomy 21 in congenital heart disease with duodenal atresia. Therefore, very, very smart to do you'll do a complete exam for everybody, but very, very smart to look in particular for features of trisomy 21. Meconium ileus and CF. We actually have a child in bed 2. I don't know if he's still there. He was there a few days ago. There's twins, one of whom had meconium ileus. The clue here, and I wish I had the X-ray. I don't think. Oh, do I have the X-ray? I might have the X-ray. We'll see. The clue to meconium ileus is you'll see a perforation with meconium ileus. Okay, but what you're really looking for is white speckling in the X-ray. The white speckling is calcium deposition from an in utero perforation. And what I'll give you some homework. If you look up, and I'm allowed to tell you, speaking now, you've got me paranoid all about Thea, but because I think it would be an excellent X-ray for you guys to look up. Baby Henry, can't remember their date of birth, but they should still be in the NICU, or they can. Bed 2, NICU. Go look up his first X-ray if you want a classic picture of meconium ileus. It's probably one of the best ones I've ever seen. So if you're curious what that is. Okay, so you might not know what this is. And I said, can't miss this one.